Thanks, Roxanne. So I'm going to talk about case selection for pneumatic retinopexy, and I'll do this kind of in a staged way. So the kind of slam dunk pneumatic retinopexy candidates, these are, I mean, if you're someone in the audience that's thinking about embarking on pneumatic retinopexy and adding that to your armamentarium, these are kind of your ideal candidates. These are the candidates, these were the inclusion criteria for the original pneumatic retinopexy trial more than 30 years ago. So the ideal candidates are those with a single tear, not greater than 1 clock hour in size, or a group of small tears, all of which are within 30 degrees or 1 clock hour of each other. And the breaks that were responsible for the detachment above the 4 and 8 o'clock meridians. So in the original pneumatic retinopexy trial, patients were excluded if they had a significant mediopacity that made you unable to rule out the presence of other retinal breaks, if they had significant glaucoma with a cup-to-disc ratio greater than 0.6, or patients that were unable to maintain the required postoperative head position. So we talk about extended criteria, and this is basically everything else. So let me walk you through some of these extended criteria, patients that I think are still good candidates for pneumatic retinopexy, or many of which are good candidates for pneumatic retinopexy. So Roxanne talked about the pivot criteria. So the pivot trial did not exclude patients that had breaks in attached retina, that had additional breaks in attached retina, and I don't think this is a significant contraindication. We just treat these breaks with laser prior to our gas injection. So here are a couple examples of those. The patient on the left has a couple breaks superiorly that are unrelated to the detachment. The patient on the right has a small hole with a small amount of subretinal fluid unrelated to the retinal detachment. If we drill down a little bit on that patient on the right, so we first treat that little hole with a small amount of surrounding subretinal fluid with laser. We inject our gas bubble, and this is a patient that we would probably, we would start out positioning face down, and then, on their right-hand side. So this is treated first, and to help prevent migration of that subretinal of the fluid from the retinal detachment to that hole, we steamroll them so that the fluid doesn't go and involve that hole. And once those superior breaks are attached, we laser those and maintain positioning until the gas is gone. So these are a little more complex. These patients with multiple breaks spanning greater than 30 degrees. So we sort of systematically reattach the retina, taking these breaks into consideration. And once everything's attached and lasered, we alternate their head positions. So let's look at an example of these. So this is a patient with some lattice inferiorly and breaks at 10 o'clock and 2 o'clock. So we pre-treat those areas of lattice degeneration with laser. And we always want to, focus on the macula first. So we position this patient on the right side, trying to reattach those 2 o'clock breaks. And once those breaks have reattached, we treat those with laser. And then we go after the other breaks and position the patient on the other side. And once all those are flat, we laser them and we alternate head position thereafter. So when you're confronted with a patient with multiple breaks that are responsible for the retinal detachment, it's wise to take a step back, take a look at the drawings and the fundus photos, and see if alternating head positions or sequential retinal reattachment is reasonable. Things like situations like this where a patient has a concurrent macular hole. So I'm talking about patients with retinal detachments that are complicated by macular holes, not macular hole detachments. I generally will go after the detachment first. It's much easier to, this patient, will likely need vitrectomy surgery for his macular hole. It's not impossible that the hole closes with fixing of the detachment, but that often does not happen. But it's much easier to peel ILM and do macular hole surgery once the retina has reattached than it is to do it in detached retina. So patients with extensive lattice degeneration, I think, are, there used to be a philosophy that if they had more than 3 clock hours of lattice degeneration, you should probably avoid pneumatic retinopexy. I don't think there's any truth to that. We will treat some patients with detachments with breaks below the 4 and 8 o'clock meridian. Sometimes that will require a second bubble, but is often successful. So large breaks, we'll show you some case examples of patients with large breaks greater than 1 clock hour in size, even giant retinal tears. It's important in those situations to your technique. Your gas injection is vital. You really want to get one big bubble. If you get a lot of fish eggs, you risk those little bubbles getting it underneath the retina in the setting of large tears. Patients with PVR, I really don't think are very good candidates for pneumatic retinopexy. I think in lower grades of PVR, sometimes you can get away with it, but probably vitrectomy is your best first option. So what about some future directions? And we'll show you some of this in our case discussion. But inferior RDs, people can do all sorts of creative things. Usually a second bubble is all you need. And here's a patient with a giant tear post-pneumatic who's had, so far, a good outcome. Thank you.
Okay, so we're going to talk about